introduce our next speaker, who is the master of ceremonies from the day. So it's a great pleasure for me to introduce Saurabh Johri to deliver a talk on the future of healthcare with AI. Now, Saurabh will be known to all of you after today, but he completed his PhD in population genetics of Imperial, did his postdoctoral work at the MRC Center at Outbreak Analysis and Modeling, and is now leads the AI research team at Babylon. So, Saurabh, thank you very much indeed.
Thank you very much, Richard. Great. So the title of my talk is The Future of Healthcare with AI. I'm going to talk a little bit about the work which we're doing at Babylon to develop AI-driven digital health products to improve health outcomes. Really, AI is central to the products and services which we're developing. And it's really key to really empower the mission which we have, which is to provide affordable and accessible healthcare to everybody on Earth. And that's a hugely ambitious statement, a hugely ambitious mission, but it's one that's required because of inequities in terms of healthcare. So this shows you a little bit of an outline of where we're operating right now. So we're in the UK, naturally. We're also operating in Rwanda. We've recently expanded into Southeast Asia with partnerships with various commercial clients. And we're also, as of January the 1st of this year, in the United States. We're also doing a number of active partnerships or projects with the Gates Foundation to expand our services into East Africa. So before talking about the future of healthcare, it's probably worth trying to understand what the challenges are in healthcare. So most of you here are clinicians, but when I normally speak to an AI audience or a machine learning audience, they don't really have this sense of what the challenges are. So really, I think one of the key challenges is access to healthcare, or rather, the lack of access to healthcare. And so this illustration here shows you the inequities in healthcare. It's largely correlated with what you would expect, other kind of economic indicators such as GDP. But actually, when you start to zoom in and look at some of the more wealthy nations, you actually see that it's not limited to just the developing world. You look at the inequalities here in the United States, one of the richest nations in the world, and you look at the relationship between a lack of access to healthcare and the associated morbidities and mortalities. And this is further reflected if you look at the county level. So how do we go about addressing these challenges? So at Babylon, we have two products, essentially. One is a virtual health product, which is essentially telemedicine. And the other is, well, we don't have telemedicine services, AI-assisted, well, an AI health assessment. And so what that does is it provides a triaging solution. So it tells you if you're sick, where's the next best action to, who should you be referred to? Should you see a GP? Should you see a clinician in A&E? Or actually, are you fine to stay at home? Beyond that, it also does health assessments. It provides you with your current and future risk of chronic health conditions. And this is how we think about developing AI-based products based off of data. So we start with the population level to look at where the burden of disease is. What is the greatest burden of disease in a particular population? We use those population level insights to start to construct personalized products to assist the patient. And then over time, with greater data from electronic health records, biometric data, biological markers, potentially even genetic sequence data, we can start to make those products even more precise. And naturally, the whole loop is tied up in evaluation. We need to ensure that everything which we're doing is evaluated, and that is central to our work. So enough of the sales pitch now. So I'm going to crack on with the actual imperatives of AI. Where can AI help us? So we've seen many of us have seen these kind of notable examples of where AI can be applied. So you've got an example in the top left-hand corner where we're using deep learning approaches to understand diabetic retinopathy from images of the eye. We've got an example in the middle here, which is recent work by DeepMind, who are looking at electronic health records, and they're trying to predict relatively early on in the trajectory of a patient whether that patient will develop acute kidney injury. And then on the right, we have an example of the ability to detect breast cancer from mammogram images. So this is great. This is showing us really impressive results based off of these deep learning approaches. But does that mean that we have a master algorithm? I mean, I think you can tell by the tone of my voice and the title that I'm here to argue that that's not the case. We've known for a long time that there is no single set of approaches which is sufficient in healthcare, or sufficient in any problem, actually. And these are the so-called no free lunch theorems. So what this tells us, as you read down here, no learning algorithm is inherently superior over other learning algorithms for all problems. And that's particularly the case in healthcare. And this is just a fairly silly example of this. So here we've got an image of a panda on the left-hand side, and we've got a convolutional neural network, which is a type of neural network. And it's correctly classifying that this is an image of a panda, and it's classifying this image of the panda with 57% confidence. So, that's fairly clear to a human that that's a panda, but, with relatively low confidence, this deep neural network is saying it's a panda. Now, if we add just a little bit of noise to this image, less than 1% of noise, and then we re-ask the deep neural network to classify this image, this now tells us that this is an image not of a panda, but of a gibbon. And it's also doing this with fairly high confidence. So this starts to illustrate why one single set of techniques, approaches, is potentially not sufficient in healthcare. Think about trying to classify a skin lesion or a mole using this type of approach, and you can think about how you might have a catastrophic failure. So this is another kind of machine learning 101 slide for those of you in the audience who don't necessarily have this background. When people think about AI these days, mostly people think about machine learning. And there are two kind of classes of machine learning algorithm. There are other classes, but these are the main classes. So you've got these so-called discriminative models on the left. So a deep neural network is the archetypal method for archetypal approach for discriminative machine learning. And these types of models create amazing performance, or provide amazing performance in terms of classification and regressions. On the other hand, they have this black box problem. They are uninterpretable. So the results or the predictions or recommendations which come from these systems are uninterpretable. So when the clinician or when the patient tries to understand how those results have been arrived at, it's not entirely clear. Additionally, those require large volumes of labeled data. So of those of us who work in healthcare, building machine learning models is often the case that there are large volumes of data, but it's very, very messy, very sparse. And so that brings me to the other class of models, so-called generative models. And so here, the archetypal model here is a probabilistic graphical model. And this essentially models the disease progress, or the data generating process. So I mentioned the issues around requiring large volumes of data, but what happens if you don't have data? What do we have in healthcare? We have large volumes of subject matter experts, doctors, clinicians, public health professionals, epidemiologists. So you can build these models using data and experts. We also have the advantages of having interpretable and explainable models. And you can also quantify uncertainty. Now, if you think about the process of constructing a diagnosis, a differential diagnosis, what is the clinician actually trying to do here? They're trying to update their prior beliefs about the underlying condition based on new evidence. And this is precisely why quantifying uncertainty is so important. The downside, however, because we have no free lunch, going back to that earlier theory, is that we suffer in terms of the speed of performing inference. So in other words, when new evidence is provided to the system, it takes it's fairly computationally demanding to do inference to arrive at recommendations, predictions, or suggestions. And it's fairly difficult to scale these models. So another way of thinking about this from a kind of behavioral science point of view is these discriminative models can almost be considered as the system one type of thinking, as made familiar by Daniel Kahneman's work in this book, Thinking Fast and Slow. So these types of methods and models provide us with fast, unconscious, intuitive thinking. On the other hand, these generative models, particularly the probabilistic graphical modeling approach, and the results and benefits you get from these provide us with system two level thinking. So slow, conscious decision-making, often in kind of complex domains. So I've talked about some of the imperatives in AI. So clearly we want to have interpretable models. This relates back to the earlier talks on the ethics, the regulation, and the legal framework. We also want this ability to quantify uncertainty, which I've just outlined, given the differential diagnosis case. But really what's starting to become very clear is, going back to the issues with these deep neural networks, what's started to become very clear is that deep neural networks, as I mentioned earlier, are essentially just applying statistical learning from data. And so what they're doing is providing insights based on correlations. And we've all been taught from a young age that correlation does not imply causation. So what we really need to do is start to inject causal thinking into our models. And so, as you see, the need for causal reasoning. And so a chap by the name of Judea Pearl has the mechanism, or one of the mechanisms, for thinking about causal reasoning. And so he has a 3-layer causal hierarchy. So the first layer is association, and this is where deep neural networks sit. They essentially make predictions, recommendations based on association. There are challenges with that, which I've already outlined in terms of bias, in terms of providing insights from correlation. The next level is interventional. So now you're able to construct a model. That model has been constructed from data or through the injection of knowledge from experts. And what you're able to do here is start to ask so-called what-if questions. So you're able to provide statements by asking questions into the model, to ask questions such as, what if I was to take aspirin? What effect would that have on my headache? Now, the answer to that question is no longer based on correlation, but has been based off of a pure causal question. So beyond this kind of interventional level is simulation. So Richard spoke about the importance of simulation. This is a different type of simulation. This is so-called counterfactual simulation. And so what you're now being able to do is ask counterfactual questions. So you want to be able to ask questions about potential interventions on individuals, on populations, and you're able to explore hundreds, potentially thousands of different potential outcomes for that patient. And of course, what we need is really accurate and safe models, and there's a huge challenge still of building models which are non-biased. So one of the ways we go about doing this at Babylon is building large-scale probabilistic graphical models, and this is an abstraction of the type of model which we built at Babylon. This is a very simple abstraction of this model. For those of you who have been in medicine for a long time, a simple example of a probabilistic graphical model is a Bayesian network. And so this is an example of a Bayesian network showing the relationship, the causal relationship between risk factors, diseases, and symptoms, showing on the left-hand side how we've parameterized or how we've added data into that model. So we've used data from electronic health records, but we've also used data from subject matter experts to tell us how often a symptom is seen when a given patient has a disease. The other important aspect of this is we're able to ensure that these models are stratified by different age groups for both males and females, and also globally. We can stratify this to reflect the burden of disease within country. So what's going on here? So this is an example mocked up. So we have a patient. That patient tells us about their symptoms through the chatbot. Here, the patient says they have stomach pain. Stomach pain is used as evidence into the model. Now what's happening is a process of Bayesian inference, where the model is updating its belief about what the underlying condition is. The model's then going to ask the next question, does the patient have fever? The patient then responds, in this case to say, yes, they have fever. And then because we know this is a slightly older patient, we're using their kind of age-specific prior probabilities, we're able to give a very specific diagnosis in this case. So that's an abstracted view as to what's happening in the back end of our chatbot. This is another example just to show a larger scale version of this graphical model. And this is a piece of work which we did with Amazon. We have no connection, just to ensure you all. But this is a piece of work which we injected our probabilistic graphical model into Alexa. And we had a patient having an interaction with Alexa. And here the patient's telling us that in this case she's got ear pain. And you can see these updating probabilities on the lower right-hand corner. The model's then asking about other symptoms, and as you can see, as the patient is providing symptoms into the model, that differential diagnosis is updating as we go. So the challenge is really, I talked about this no free lunch theorem. You have these challenges in terms of interpretability on the one hand with these deep neural networks, and these advantages of having interpretable models on the other hand. So wouldn't it be great if we could combine these two approaches? And that's exactly what this paper does. It combines the approach of using a deep neural network to perform tractable computation into the model, whilst also giving interpretable and explainable results. We don't just use this for inference, we also use this to scale the localization of our models. So one of the other downsides I mentioned about these probabilistic graphical models was the ability to scale these models. So clearly what we have is models, for example, in the United States, and we want to scale these into Asia because that's where we're operating. How do we do that when we don't have data or good quality data in each region? Well, we're able to use different approaches, in this case, so-called domain adaptation approaches, to transfer knowledge from one model to the other. This is, again, just a schematic of what's going on. So essentially, we have a source model which is of high quality because it's based on high quality data, and we've had a lot of experts working on this model to refine it. But then we've got a target model which we want to release a model into a new country, but we don't have good data for. So what we can do is borrow parameters and data from the source model to transfer it across to the target domain. So what I've showed you so far is about a static diagnosis and triage outcome. But really what we want to be able to do, recognizing where the costs of healthcare are, is look at patients as they progress in their condition over time. Going back to the framework of population, personalization, and precision, now we've got population-level data in our electronic health records. We perform some population-level insights on that data, and we look at the burden of disease here. So in this case, we're looking at the burden of disease based on some health economic indicators, QALYs and DALYs typically. And then we're saying, okay, in that population, the largest burden of disease is in patients with COPD. So what can we do? So we can create products, personalized products, which are based on evidence-based care plans. So those care plans are then integrated into the product. And now, importantly, what we're able to do is to start to perform simulation. So this is a patient with a particular care plan, has a hospital checkup, has a given intervention, and they have a likelihood or a medium risk of being admitted to accident emergency. Now, what if we were to ask a counterfactual question of that patient to say, what if we were to change your care plan to care plan B? What would be the impact? And now we see the risk changing from medium to low. Of course, this is just a kind of a mocked-up version of what's happening under the hood. Just to take this one step further and really start to understand what's going on here, this is an area of simulation, of causal analysis called counterfactual simulation. We actually just released a paper this morning which was published and has gone into one of the leading conferences in AI, AAAI, outlining some of this work. So we know that populations, or the population level risk is just that. It does not reflect everyone in the population. So we know, as an example, that if you exercise 3 hours more per week, then we'll reduce your risk of heart disease by 30%. But that's just the population level estimate. We know there is significant variation within the population, reflected by these lines here. Now, we know this patient has some risk factors, so they have unhealthy diets, they have a family history of diabetes. Based off of this, we might be able to say that if they exercise 5 hours more per week, unfortunately, that will reduce their risk of cardiovascular disease by 20%. Now, if we're able to ask counterfactual questions, for example, what would happen now if you were to improve your diet with this background of a family history of diabetes? Now, what would be the impact? So you can ask really granular questions using this type of approach. These approaches are, as I mentioned, personalized, because they're able to use past medical history of that patient, but they're also able to simulate more than one potential outcome. So they're able to look at many different simulations and determine the optimal simulation. And you can then use those simulations or the insights from those simulations to inform the product. So one of the other parts that I mentioned was that obviously we want to be able to evaluate everything which we're doing. And so here we think about evaluating our products in the same way that we would evaluate pharmaceutical intervention. So we want to think of software as a drug. And this is a new paradigm which we're following and which we're using to evaluate all of our products. And with that, that's my talk.